So it's my pleasure now to introduce as the next speaker Dennis Wolf. Now it is a pity that he cannot, in the last moment he couldn't come in person. I wished he would have come actually. Dennis, I know him for a very long time. He came in the year 2005, just after the return of my postdoc with Peter Libby, as a young doctor into my lab and said he wants to do science. And ever so he's done greatly. He just earned an endowed professorship in Freiburg, sponsored by a big foundation for immunology. He did a postdoc with Klaus Ley, who is like one of the cardiovascular immunologists in La Jolla, and worked a lot on immunologic factors. He will talk today about the cardiovascular patient with diabetes, a special subgroup. And let's play the video.
Hi everybody, this is Dennis Wolf from the University Heart Center in Freiburg, Germany. Welcome to this virtual presentation.
We cannot hear the voice.
I would like to talk about the patient
much louder
with diabetes mellitus and cardiovascular disease.
Much better.
And about what makes this patient really specific.
Even louder.
So let's start with an observation in coronary angiography that you see on the left side. And this picture really shows you the specific characteristics of coronary artery disease in diabetic patients. What you see is really a multi-vessel and multi-lesion disease that can be very extensive. And on the right side, you see that this kind of extensive coronary artery disease is much more frequent in diabetic patients compared to patients that don't have diabetes. In addition, you see that in particular, left main vessel disease is much more frequent in diabetic patients. So that shows you that the degree of coronary artery disease in diabetic patients is much more severe than in patients without diabetes. In addition, we do know that interventional therapy is limited in diabetic patients. That's shown in this study published in JACC in 2019, where 1,900 patients with type 2 diabetes mellitus and multivessel disease were randomized to either bypass surgery or percutaneous coronary intervention. And what you see is that the mortality in patients treated with PCI is much higher than patients treated with bypass surgery. So that shows you that our interventional options are limited in diabetic patients, and that's another indication that the diabetic patient has coronary artery disease that is much harder to treat than patients without diabetes. Let's now look at the specific risk for cardiovascular disease caused by diabetes mellitus. I'm showing you an analysis of the emerging risk factors collaboration from 2010, which is a meta-analysis of more than 100 prospective trials and almost 700,000 data points. What you do see, and this is really the number that you need to keep in mind, is an almost twofold increase for several cardiovascular entities, such as coronary heart disease, coronary death, non-fatal myocardial infarction, and also several subtypes of stroke. So the risk that is conferred by diabetes mellitus to develop those cardiovascular complications is almost increased by twofold. Those numbers have been validated in other studies, such as in the study I'm showing you here. That's a cohort study in almost 2 million people that again shows you that the risk for cardiovascular disease is much higher in patients with type 2 diabetes mellitus. But what is really interesting, and that's shown on the right side, more than 2/3 of patients with diabetes mellitus die of cardiovascular disease. And this ratio is much higher than in patients without diabetes mellitus. So that again shows you that the diabetic patient is at a high risk for cardiovascular disease, and specifically those complications that are caused by atherosclerosis. The question, however, is what defines a patient with diabetes. Of course, we do know that HbA1c levels above 6.5% meet the definition of diabetes mellitus. However, the study I'm showing you here, published in JACC in 2021, shows you that this is not completely precise or true. Because now what the authors of this study found is that when you perform multi-region imaging by coronary CT or by ultrasound in the carotid arteries, you do find an enhanced incidence of atherosclerotic lesions at those locations, even in patients that do not meet the criteria for diabetes mellitus, but that instead meet the criteria of pre-diabetes, which was defined as an HbA1c above 5.6%. So that shows you that this is a continuum between a healthy patient and a patient with diabetes mellitus. And patients or human beings are at an enhanced risk of atherosclerosis even at the level of pre-diabetes. What is interesting is that based on those findings, it may be somewhat plausible to define anti-diabetic therapy even for...
Sorry for the interruption, because the slides are not moving. So we make a fixation here. في خلوهم ينتبهوا بس من ما يسيبوش
Hi everybody, this is Dennis Wolf from the University Heart Center in Freiburg, Germany. Well, right side is associating with increased cardiovascular death, for instance for myocardial infarction, as shown on this slide here. So there is a clear association of increased HbA1c and cardiovascular death. The question, however, is whether the role of HbA1c is causal or is just an association. This question can be answered partially by looking more closely at the ORIGIN trial published in 2012. In the ORIGIN trial, an intensified therapy with insulin glargine was tested against standard care. So that's an improved therapy to lower hypoglycemia. You do see that this works pretty well by looking at HbA1c levels under intensified therapy and standard care therapy. So intensified therapy is very good to lower HbA1c levels. However, when we do look at the cardiovascular outcome, we don't see any differences. So, in other words, intensified therapy with insulin as an improved way to lower HbA1c and to normalize hypoglycemia works, but it's not very efficient to improve cardiovascular outcomes. So hypoglycemia in this context is not causal. And this is a problem because over decades, therapies like insulin to lower glucose levels in the blood have been promoted to protect from cardiovascular disease, but actually this was not true. Only recently the development of GLP-1 agonism and SGLT2 inhibition, as you know, has proven to be an effective therapy to improve cardiovascular outcomes. And this has been shown by many studies, some of which are shown on this slide. What we do see in those studies specifically is a very clear dissociation between HbA1c levels and cardiovascular outcomes. For instance, GLP-1 receptor agonism lowers HbA1c and lowers cardiovascular complications. Same is true for SGLT2 inhibition, but it's totally not true for DPP-4 inhibition or for insulin. So this is indicating that modern anti-diabetes therapy must have non-glycemic modulating mechanisms, likely a cardiac mechanism for SGLT2 inhibition and likely a vascular mechanism for GLP-1 receptor agonism. This idea is further substantiated by meta-analysis, such as the one shown on this slide, published in 2019, that shows that in particular vascular complications such as non-fatal myocardial infarction and non-fatal stroke are only lowered by GLP-1 receptor agonism, but not by SGLT2 inhibition. SGLT2 inhibition on the other side, and that's shown on the lower right side here, is pretty effective in reducing cardiovascular complications that are caused by heart failure. As you do know, SGLT2 inhibition by dapagliflozin, and this has been shown in the DAPA-HF trial, is very effective to improve heart failure associated outcomes in patients with heart failure with a reduced ejection fraction. But the same seems to be true in patients with heart failure and preserved ejection fraction. This has been shown in the Empiria Preserved trial recently, testing empagliflozin in HFpEF, again showing that heart failure associated outcomes were greatly improved by SGLT2 inhibition. Again, this year during ESC conference, it was presented that dapagliflozin is likewise equally good in reducing heart failure associated endpoints in patients with HFpEF. The interesting thing here is that this mechanism is totally independent of diabetes mellitus. So subgroup analysis clearly shows that it does not really matter whether the patient has diabetes or does not have diabetes. SGLT2 inhibition is working independent of type 2 diabetes mellitus in improving heart failure associated outcomes. So based on the findings I showed you, we may propose a CVD-guided therapy of type 2 diabetes mellitus. It is important to initiate lifestyle management and body weight reduction, although this can be very challenging for patients. And this is the first step. Then, of course, we have to add metformin, which is still recommended by diabetes associations. But then the use of SGLT2 inhibition or GLP-1 receptor agonism may be guided by cardiovascular comorbidities. So it is somewhat likely that patients with obesity and vascular complications such as atherosclerotic cardiovascular disease may benefit from GLP-1 receptor agonism to a higher degree than patients with established heart failure. Those patients may benefit much better from SGLT2 inhibition. This is the case for patients with HFrEF, and it may also be true for patients with HFpEF. Also, this is not yet recommended by guidelines. So let me end this talk with another observation. You already heard today about anti-inflammatory therapy of atherosclerosis. The two drugs that are important in this context are canakinumab and colchicine. So it is important to highlight that diabetes mellitus may be a source of inflammation that is contributing to enhanced levels of inflammatory mediators such as interleukin-6 or CRP. The interesting question, however, is how anti-inflammatory therapy modulates diabetes. This was tested in a sub-analysis from the LODOCO-2 trial that first shows, and this is shown on the upper side, that patients with diabetes mellitus had a much higher risk for developing cardiovascular complications than patients without diabetes mellitus. So this is pretty much in line with what we heard in the beginning. Now, interestingly, the efficacy of colchicine in this trial, when we stratify for patients without diabetes and with diabetes mellitus, was not statistically significant. So it seems to be the case that colchicine is working to the same degree in patients with and without diabetes. But what was really interesting is that the incidence of new onset diabetes mellitus was much lower in the colchicine group than in the placebo group, indicating that potentially anti-inflammatory therapy may prevent new onset type 2 diabetes mellitus. And this is a very important facet of anti-inflammatory therapy, and it may finally be tested in upcoming trials such as COLCOT type 2 diabetes mellitus, which is currently in preparation. With this overview that summarizes the use of traditional and modern anti-diabetic therapy in patients with type 2 diabetes mellitus, I'd like to close. I hope that I have convinced you that patients with diabetic mellitus indeed represent a very special subgroup of patients with cardiovascular disease, and that this subgroup really requires intense treatment. I'd like to thank you for your attention, and I'm happy to take your question afterwards. Good evening.
Yeah, so I think we will move directly on, because unfortunately we didn't have a technical possibility to have those questions answered. I think this was a very nice last slide that shows differential treatments, and that we are with the inflammatory collective, we will use more the GLP-1 agonists. With heart failure, kidney endpoints, we are probably more successful with SGLT2. I would add, in the very high-risk ones, we need to combine both. And what I also liked is, I mean, what you see there again is the differential risk assessment and differential treatment is getting into any of those subcollectors of our medicine.